Welcome to the Clinical Education Initiative podcast, Conversations with CEI, where we feature conversations with clinical experts, their experience and insights on current health issues in the areas of HIV, primary care and prevention, sexual health, hepatitis C, and drug user health.
Hello and welcome. My name is Margie Urban. I'm an infectious disease physician at the University of Rochester, and I'm the principal investigator for the CEI, or the Clinical Education Initiative Sexual Health Center of Excellence. And I am very happy to welcome our guest today, Will DeWitt from Northwell Health. And maybe, Will, I'll let you introduce yourself to our audience.
Hi, everyone. I'm Will. I am the clinical director of anal health at Northwell now. I've been here since December. I was at the Callan Lord Community Health Center before that for almost 10 years, and I was the director of anal health there as well. So it's been my job and my role, especially to focus on anal cancer prevention, especially for HIV positive folks. And I'm also a primary care doctor. I'm a family medicine doctor, did my training at Montefiore in the Bronx, and I do regular primary care and HIV care as well.
Well, that's the reason we're here, is really to talk a bit about anal cancer screening and HPV. I was recently at a meeting where you were also present, and you gave a talk to the group of us at the meeting where you mentioned a coalition that you were part of that was forming in New York City about anal dysplasia. And that's kind of what led to this podcast here. So before we get into talking about the coalition, maybe we'll just do a little bit of background about anal dysplasia and the current recommendations for screening, particularly in persons with HIV.
I think there's a big focus on implementation right now because the guidelines that used to be pretty unique to New York were the New York AIDS Institute. And that's why it was so wonderful to present at the New York AIDS Institute, because we have this history of advocacy and really trying to push this forward for a lot longer. But recently, the CDC and NIH, so part of the HIV guidelines in general, is now recommending intervention. So recommending screening for anal dysplasia and treating to reduce the risk of anal cancer for all people living with HIV. And so that guideline is focused on just people living with HIV, and it's specifically anyone over the age of 35 who is men who have sex with men, and also trans women, and then all other HIV positive patients over the age of 45. So that includes straight cis women and straight cis men and the entire gender spectrum. And then the New York AIDS Institute actually includes trans men who have sex with men as well for the 35 plus group for people living with HIV. And then also make a special note about people who are status post solid organ transplant, especially people who are 10 years out. They have a very high risk as well. And all of this is driven on data around anal cancer incidence, right? Because anal cancer is still a rare cancer for the general population, but it is a very common cancer in these specific populations. And the other guideline that people should just be aware of is the International Anal Neoplasia Society guideline. So IANS is the group that has been driving the research and the treatment for a long time, I think since like the mid to late 90s, starting at UCSF. But IANS is now an international body, and they had the most broad recommendations. So they base it entirely off of incidence, which makes sense. So 17 per 100,000 is their cutoff. And that includes, with some evidence, HIV negative MSM over the age of 45, because especially if you look at over the age of 60, it goes past that threshold, which I think is a good idea. Because obviously those other bodies are focused specifically on HIV positive populations. But I think if you're looking at a broader lens, it makes sense to include all people who are at risk and really using that risk as a driver for who to recommend this for.
That is a question actually that comes up quite often clinically, I think, from our patients who may be on PrEP. So they're not living with HIV, but they have some risk.
And I think that's a wonderful thing. I think especially the MSM, like gay community, have a strong relationship to public health. I think a lot of us are used to, like, with PrEP, and even like what we saw with the Mpox outbreak a couple of years ago, which I was at Callan Lord when that happened, and it was very intense. But just the way the community kind of came around, and they're very public health aware and are ready to line up for a vaccine right away, right? So I think, it's like great that a lot of people are proactive, and the lines of communication, I think, are really strong in those communities too.
So we're both in New York, and I'm in upstate New York, you're in downstate New York, and both work with the AIDS Institute. And I think we felt a little vindicated when the national guidelines caught up a bit with the New York guidelines. So that was good news. So maybe we'd talk a little bit about what does screening actually mean? I guess screening, there's several different tools.
Yeah, so those are the groups that we want to screen. So yeah, how to screen is the next part, and that is relatively straightforward. It's the same thing. And just a interesting, curious thing to know is this is all HPV related cancers. So very similar to cervical cancer. And we borrow a lot of the technology from them, and it's a lot of extrapolation from cervical. But yes, it's a pap smear. So we call it a pap smear, really anal cytology. So looking at skin cells from the anal canal that you collect with just a swab. So easier to do than a cervical pap, where you just, it's kind of like if you do a gonorrhea chlamydia swab, it's really similar to that, where you're just blindly collecting skin cells in the anal canal. And then you can also do co-testing with HPV. There's some nitty gritty with the HPV testing where there's different ways to test for HPV. But that's the basics is anal cytology and HPV testing, sometimes co-testing, sometimes triage. And that's where we get it a little messy in the guidelines because there's lots of ways to approach that and risk stratification. So now that we've kind of solved and very definitively said that this is an effective intervention for people who are higher risk for anal cancer, now we're getting into like implementation and risk stratification. So I think it gets a little confusing around co-testing and HPV testing. And that's because we're trying to figure out the best way to risk stratify people after we decided if we're going to screen it all. But even that, I think it gets back to one big difference between cervical and anal is that we have a lot more abnormals. So in these populations that we're screening, the rate of high grade is much higher and the rate of HPV positivity is much higher. And that might change hopefully in like 20 or 30 years with HPV vaccination, especially because we're screening, the age cutoffs are much higher. So a lot of people, especially assigned male at birth folks, did not get the HPV vaccine when they were younger. So it's not surprising that we have such high rates, which also unfortunately means it's not a very powerful tool for stratification because if most people are positive, that doesn't help a ton. But if all you're doing is anal cytology, the threshold is also a lot lower for referrals. So if you just have ascus without HPV testing, that's enough to refer someone to HRA.
What do you think of self-obtained?
Yeah, so there was a recent meta-analysis, and I think even at CROI, they presented some new data. And basically the takeaway is that it seems HPV testing is pretty concordant. So it's very similar, self-collected versus clinician collected, but cytology takes a sensitivity hit. So it's about 10% in that meta-analysis that just came out. Yeah, but I think my own kind of take on it is it's obviously off-label. And I think we do this all the time as clinicians is it's a little bit of a harm reduction that some screening is better than no screening. So absolutely, there are a lot of patients, especially if it's a new thing. And now I've implemented this at a few places that are entirely screening naive. And it's a totally different thing than a place like Cal and Lord, where they've been doing it for a couple of decades. And a lot of patients, they know the role already. They know the routine rather. At new places, especially, I think there's a little bit of hesitancy, and that's absolutely understandable. And if a patient is more comfortable doing it themselves, it's better than not doing anything at all. I think my biggest concern, and this is a real concern, is that if you don't do it yourself, if a clinician doesn't do the swab, they often skip the anal exam entirely. And that is part of the guidelines is that all of these folks are supposed to get a digital anal rectal exam as well, because that's really the screening test for cancer. So the PAP is not a screening test for cancer. It's really a screening for dysplasia, which is the precancerous high-grade lesions. But the digital anal rectal exam is really the best way to make sure that we're not worried about any anal masses. And I've seen that. Actually, I just had a patient last week who'd been avoiding coming in for screening, and he had a hard mass, and it turned out to be cancer. So kind of a timely reminder that this work is really important.
So then as you look at those flow charts of how to screen, so you have the anal cytology or the anal PAP with or without your HPV testing. And then if it's abnormal, then there's the next step, which is high resolution anoscopy, right? Yeah. And that's hard to find in some places.
Yes. And this is, that's the huge shift, right? Now that it's kind of been enshrined in guidelines, people really want to do it. But then the next step of like, oh, but no one knows how to do this next step. And that's even part of the guidelines from the NIH is that you should only be doing screening if you have readily available high resolution anoscopy. Because what do? Having an abnormal result isn't very helpful. You should still do the digital anal rectal exam. But if you don't have access to a high resolution anoscopist, you really shouldn't be screening for dysplasia, but definitely continue screening for anal cancer, right? And you're absolutely right. That's a huge problem. And trying to get people up to speed and trained on HRA is a sticky knot of a problem too, because it's hard to get training when you're in your mid-career. And a lot of people are interested in doing it, but it can be hard to get that, especially if you don't have many people around. And so one of the nice things about New York, and especially New York City, is there are a lot of us who do it. And so a lot of people can get trained within their institutions. I mean, that's what I'm working on right now at Northwell, is I'm starting to train some more folks. And I think there's also more interest in HIV fellows getting trained. So I've heard of, there's already a fellowship program. I think it's in Atlanta with Nina Flowers, who used to be the president of ASCCP. So she has a fellowship where she's training people on HRA. But this is a big problem. And one that Ian's especially is focused on is this next step of ensuring that access is going to be there. And then not only that, but ensuring that when there is an HRA provider, that their quality is also high. So that's an ongoing, it's really interesting to watch that kind of shift in focus in a big way.
That sort of creates a divide, it seems, in sort of urban and rural locations, and maybe even state by state. As you say, New York has had this recommendation for quite some time.
Yeah, and even countries too.
Uh-huh.
Yeah, because there are some states where there's only like one, if any, people who do HRA. And so I think there's kind of been a focus in California and a focus in New York. But you're totally right. There's a lot of places where there's a desert in terms of HRA availability.
So that really is what led to this meeting that started our discussion. And I have here the intro, that the invitation, the New York City Metro Anal Dysplasia Coalition meeting. That was your formal title. Do you have an acronym?
Yeah, we actually, so at the meeting, we decided on an acronym name. And of course, it's a little cheeky. So it's called ASSETS. Anal Screening, Surveillance, Education, Treatment Services. And the idea is like Assets NYC. The organizer was actually Cheeky Charity, so also a cheeky name, literally. And the main organizer is this man named David Russo, who is not a clinician, but is very passionate about helping to prevent both anal cancer and colorectal cancer. And he's started that organization. I'm really excited for that. It was actually amazing. We had the meeting a couple of weeks ago, and just having all those different people who work on the same problem was really wonderful. The idea behind the coalition is, I think, especially in the United States, like we're all very siloed, right? Like, so even within institutions and within big institutions, sometimes we don't even talk to each other, let alone like within institutions. And I think what is unique, and I think part of like why we got a good turnout, is that if you're doing this kind of work, I think sometimes you can feel a little isolated to begin with, because not many people do it. And, you're often explaining yourself and explaining why it's important and how to do it. So I think there is a real thirst for information sharing. And I think that kind of collaboration. So I think the idea is we're all doing the same thing. It's all ramping up right now. And there's now this like kind of renewed interest. So I really want better lines of communication between all the people who do high resolution anoscopy, the people who are screening, and also the people who then treat more complicated cases. So surgeons and oncologists when cancer is unfortunately diagnosed. Yeah. And one of the things, kind of what you're getting at in terms of like HRA availability, is to increase referral pathways, right? So if you're at a place that does a lot of HIV care or LGBTQ care, but you don't have an endoscopist, it's just good to know who in the city would actually be able to see your patients. I mean, I think in New York City, we had the capacity to start to really expand that. It gets more complicated even upstate. I know at Rochester, you have a few people who do it, but yeah, that's the idea. And then beyond that, so that's kind of very concrete next step. And we've already built that directory, and we're going to clean it up and make sure that it's really something that's usable. So knowing where are the places that you can send your patients. So now you want to start screening. So knowing where you can send out, especially within the city. And then I think my other hope is that, and this came up at the meeting, but it's much more a thorny issue of, people who are at different clinics that want to be trained, and how training can happen too.
And is the training like a standard curriculum that has a certification, or is it experienced provider training and inexperienced provider?
So for the longest time, the main training, and it continues to be pretty much the main one, is through Ian's. Back when I did it, it was actually under the wing of the ASCCP, which makes sense because colposcopy and HRA are very similar. So since then, Ian's has branched out and it's not as formally under the ASCCP's wing, but they still do the course. So, and it evolved during COVID, where now there's an online course with an optional hands-on portion. So that's still a really wonderful and like incredibly comprehensive, like it's a great training. The hard part then is you do that training and you do maybe one day of hands-on, but then you really need some mentorship. for ongoing training and to feel fully competent in it. It's also, even in the literature, we've shown that this is a procedure with a high learning curve. And kind of like no self-swab is better than no swab. A new provider doing it is better than no provider doing it. And especially with some guardrails around like making sure that quality continues to improve. But there really is a need, and that's the hardest part, is getting that mentorship afterwards. And this is a problem that we don't have easy answers for yet. It's a lot easier. I was really lucky at Cal and Lord where there's 3 other providers who already did it. And they even brought in some people who used to do it to come and do some training for me. And that's easy because it's within your own institution. So you don't need to worry about all the medical legal barriers, because that's kind of the biggest part. But when I did training at Mazzoni and I did training at Brown, it's a much more complicated process to get privileging to come in and be able to do that mentorship. It's a huge time and investment. It's an investment of both like time and treasure for sure, too.
When I was thinking about coming into this and what our conversation would be, I was trying to think of other guidelines where they recommend something that you can't get. And I couldn't really come up with anything. It's like the guideline is driving the practice.
Yeah. Well, so I think it is like a chicken and egg thing. It's right. Even like electric vehicles, like you need charging stations.
Exactly. Yeah.
We're not alone in this being a problem. And that's why the guidelines give you that kind of like, as a clinician, you're not deviating from standard of care if you don't provide the service, if you don't have the capacity. But I think it was really important to have these guidelines saying that this is an important thing to do if you can do it, because that now is causing all of this investment and all of the infrastructure building that we really wouldn't have had and we didn't have because it wasn't enshrined in guidelines in the same way. And actually, I don't know if I remember back in the day, for like a more direct primary care example, there used to be a guideline of to even do depression screening unless you have behavioral health resources, right? Uh-huh. And I've unfortunately worked at places where there weren't many behavioral health resources. So yeah, sometimes it's better not to go. And I think that's since been changed because most people can intervene on depression. But a similar kind of sense of it can sometimes, the balance of if you screen someone and you have nothing to do with it, you might be doing more harm than good. And I think that's okay.
So after your meeting that you said you got pretty good attendance, do you feel like there's capacity for the population who needs this?
Yeah.
At least in New York?
Yeah, I think in New York City, absolutely. Yeah, I think smoothing those pathways. So I'm at Northwell, but I'm already working with a few places. Part of my job is to build capacity at this very large institution. So I think there's a lot of potential for growth even at my one spot, right? But I think already there are places that have the ability to take outside patients. Yeah, so I think in New York City is kind of unique in that there is, I think the only place that's kind of comparable would be San Francisco. And I think part of that is if you don't know, you don't know. And if you don't know the players or the people to ask, you may not know that some of these resources exist. That's definitely one of the main goals of the coalition, is to make that more apparent. And like harnessing that too. I think the other part of the coalition is really harnessing now all these people who are doing this work in much larger numbers than is done in, I can even say, the world, right? And harnessing that then to drive further research as well. So I was really excited that we had some researchers at the coalition too, because there are these open questions, both about implementation, but even just clinical questions about risk stratification and things too. So I think there's a huge opportunity, especially in New York, to both improve care, also connecting people to these services that do have capacity and do exist, and then also to capture the amount of work that's already being done and harness that to drive further research too, is another goal.
And you said you already have a directory. And so do you envision that directory as being sort of publicly available that patients would know?
Oh, yeah. I mean, it's geared towards clinicians. But I think the idea would be, even patients would be able to access. Yeah. And the meeting just happened a couple of weeks ago and we need to clean everything up to make it as usable as possible. But that is absolutely the goal.
Yeah. And so then for the rest of the state, there are, little pockets of where people do have capacity. As you said, in Rochester, we have some access, but that's generally true for HIV care, even that it tends to be more concentrated in the urban centers.
Yeah. So people are kind of used to traveling already.
Yeah. Yeah. But for this, I could even see people traveling to New York City because there's,
yeah, it's possible. And I do have patients who have traveled. I've even had upstate patients come down to New York because they know that people who are very good at self-advocacy and they are able to do that. Obviously, that's a pretty high barrier for people who have, a lot of different reasons where that might be a challenge. But absolutely, yeah, I think that would be So having it publicly available, I think, would be helpful because then people can kind of advocate for themselves and find that care if they really want it.
So just before we wrap up, your coalition, I think you said, was called Assets. That's the acronym now. If there's someone who would like to get in touch and maybe become involved, is there a contact info that you can give?
Yeah, so people can feel free to get in touch with me. My email is wdewitt, DEWITT, @northwell.edu. And yeah, if people are curious about the coalition or want to join, we're going to have our first planning. So our follow-up after the larger meeting, we're going to have a series of planning meetings. And the next one is going to be in a few weeks. So yeah, anyone in New York, a lot of us are in New York City, but we do have some Rochester representation, and we would love to get anyone else from New York as well. And yeah, right now it's called Assets NYC, and David at Cheeky Charity is hoping to expand this to other cities and other places, and even learning from how we're doing it in New York to implement it other places. I know there are some there's an informal one in the greater Boston area because that's another kind of focal point because Fenway has been doing it for a while there as well. But yeah, the idea is to make this reproducible and expandable to really kind of have as broad of a coalition as possible. But yeah, if you're interested in Assets at New York, feel free to get in touch.
If you'd like to learn more about us or join the coalition, please visit www.screenyourbutt.org/NYC or email david@cheekycharity.org.
Okay, great. And so just to clarify, we are now recording this in early April of 2026. So the planning meetings are coming up shortly, the spring of 2026.
Yeah. And the other thing we're planning or hoping for is that in a year, we want to have a larger symposium. So this meeting that we had a couple of weeks ago was really for the people who are already doing the work, but we're also hoping to have more of a conference next year.
All right, great. Well, thanks so much for joining us. It was really great to hear about this and good to know that really it's building the infrastructure to implement the guidelines is what your group is doing, which is really important.
For the people it matters a lot. And I think it's care that everyone deserves if they are at risk. So I'm really excited and happy to see the interest expand and all the energy around it right now, which is great.
Well, thanks so much for joining us. Our podcast is Conversations with CEI. So I've enjoyed our conversation.
Yeah, thank you so much for having me. It was wonderful.
Thank you for tuning in. Join us next time for a new episode of Conversations with CEI. Visit us at ceitraining.org and follow us on CEI social media platforms.